alarm is dinging every day in every ER, and the patients just keep coming in, and we're expected to keep trying to figure it out. So, and eventually people say, you know what, this is enough. Like, I'm not going to keep doing this. And so I hope that ACEP can help be part of the solution to push back on that and say, you know, this isn't okay anymore.
Welcome to How I Doctor, where we're bringing joy back to medicine. I recorded this week's episode in person in Salt Lake City with my guest, Dr. Alison Haddock, the president of the American College of Emergency Physicians. We also had our first in-person off-call event, and it was a smash hit of physician entrepreneurs and innovators. It was an honor to speak with Dr. Haddock, one of the clearest, fiercest advocates working for our specialty right now. She and I talked about the things that keep emergency docs up at night: physician autonomy, ED crowding, ED boarding, the financial pressures squeezing our profession, and what real workforce empowerment could actually look like. We go deep on policy issues affecting ER docs and the day-to-day stuff that matters too: staffing, violence in the ED, and whether transparency around pay and contracts might finally change the balance of power between clinicians and employers. Fair warning, this is conversational, sometimes blunt, very human, because the crisis in emergency medicine isn't a data point. It is our people. Let's do this. Here's my conversation with Dr. Alison Haddock. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. Before we jump into today's episode, I want to give a huge shout out to our first ever How I Doctor podcast sponsor, Abridge. Abridge is the leading AI platform that drafts structured, clinically useful notes at the point of conversation. Clinicians remain in full control because they review and finalize every note. With Abridge, many clinicians report reclaiming time and reducing their documentation burden, myself included. I've been using Abridge in my role as a practicing emergency physician in San Francisco, and clinicians who use it report up to an 86% reduction in effort writing notes, a 78% reduction in cognitive load, and 70% decrease in after-hours documentation. The company was also founded by a physician and is completely dedicated to empowering clinicians, which is what makes them the perfect first sponsor for How I Doctor. If you aren't yet using Abridge, inquire with your IT department today or reach out at abridge.com/contact. Thank you, and now let's get to today's episode. Dr. Alison Haddock, welcome to How I Doctor.
Thank you.
Thank you so much for being here.
I'm excited to be here.
We are live in Salt Lake City. We're not on a screen to each other.
Nope.
Tell me a little bit about yourself, Alison.
Sure. So I am an emergency physician. I trained at the University of Michigan, did my residency there, finished and went in the community for a few years, got sued. It was a little rough. Loved working with my scribes more than anything. And I was like, that's the teaching part. So kind of shifted to academics, moved to Baylor College of Medicine and was there for 10 years. And while I was there, started on the board of directors with ACEP. And
Amazing.
So I've been doing a lot of work with them for a lot of years. And this past year, I just finished my term as president.
Congratulations.
Thank you very much.
Alison, I wanted to talk with you today because I think you're such a great voice and advocate for emergency physicians.
Thank you.
It is a tough job that we have.
Yeah.
And I think it's important that we have leaders that support us and really understand the challenges that we face. Alison, let's talk a little bit about ACEP 2025 and what were the key themes that you really took away from the conference?
The conference has gone really well this year. I think people have loved being in Salt Lake City. I've been joking for years that it's like going to be like the hikey bikey conference.
There is a wilderness subculture
Yeah,
of emergency medicine that
exactly.
I am not personally part of. I'm more on the tech nerd side, but I know plenty wilderness
Yes.
ultra marathon people that
love
love
Denver.
that. Yes.
Like our
Yeah.
people love Denver. And I was like, I think Salt Lake City can be like mini Denver. So that has been really fun. I've enjoyed the sessions. We have a lot more sessions these past couple years that are not strictly CME sessions as
Sure.
well. So we're calling them off track, and they really give people an opportunity to submit things later in the game. So if you have ideas out there, feel free to submit them to ACEP. There will be a chance closer to before we meet next time in Chicago and do some non-clinical topics, as well as we've tried to really enhance our opportunities for networking.
Yeah.
Like you can get CME anywhere, but you can't be with thousands of other emergency physicians anywhere, any time of the year. So leaning into that.
Alison, we talked a little bit about just workforce autonomy.
Yeah.
What does that really mean to you? What is your vision for what autonomy means for an emergency physician?
So I made physician autonomy kind of a key theme of my presidency, because when you look at emergency medicine, we see that people are burning out, people are leaving the specialty, people are frustrated, and thinking about the root causes, like we've all gotten to the point where we're like, okay, it's not the yoga, it's not the pizza party that's going to solve these problems. And if emergency physicians were truly running the show and making all the decisions at the hospital level for themselves, I don't think we'd have the burnout that we have right now.
I completely agree.
I think it's the loss of professional autonomy that's leading people to leave the field.
I really feel like we are like stuck in the middle of the patients coming in the door, us trying to move the patients either upstairs or the ICU or discharge them, but we don't have and the expectation that we do that efficiently and accurately and quickly, but we don't have the levers and the power to make the resources to make that happen. That I think is the most frustrating piece. Like, hey, you have all these things that you say are my responsibilities, that are my demands that you expect of me, but it's like with a blindfold on and one arm tied behind my back because you're not giving me the power to control my destiny, to give me the tools I need to move patients through the system really efficiently and communicate with them and do all the things that you expect of me to do.
Yes. And having a physical space to care for a patient should be the absolute bare minimum resource that we give emergency physicians. And we're not giving that to us.
I sometimes wonder if we are victims of our own success, that we are too accommodating. The amazing thing about emergency physicians is we can deal with anything.
Yes, we can.
And we are so proud of that. You can come in with any chief complaint, and it is my responsibility what the heck to do with you.
We'll figure it out.
We'll figure it out. But the consequence of that is we'll figure it out. And so when the waiting room is full, we'll figure it out. So we kind of decided to say, well, I don't have an alternative. The only tools I have under my disposal is we could put a patient in the hallway there versus, stereotypically here, if we were surgeons, I think a surgeon would just say, well, no, I can't do that. Or I will not do that.
Tell a cardiologist, here's a STEMI, you have no cath lab. Why don't you do it in the closet? And they're going to say, no.
Absolutely
And
not.
an emergency physician is going to say, okay, like the patient needs a cath, like let's figure it out. So that I totally agree with the fact that we are victims of our own success.
I think part of anesthesia is you are ultimately responsible for this life that you're putting under, and you're responsible for if they get a corneal abrasion and if they have some sort of injury and if the surgery goes wrong, telling the surgeon to stop. Like you are ultimately responsible for that. And in some ways, like I'm kind of jealous that they have the ability to say, I am in charge of just this one human being. And so they can say, nope, it's not safe to start this surgery. So I'm literally not going to start this surgery. For us, I feel like I feel a little bit more pulled because I see a waiting room that's full. I see patients who the healthcare system is missing, and so I they're coming to me for help and assistance. And so like I would love to have that pull the lever on the car manufacturing line saying no, we can't keep going. But it doesn't feel like there's almost like a public healthy version of the safety net that we have this responsibility. And so we're trying to be accommodating to do the best in a bad situation.
Anyone, anything, anytime.
That's right. That's right. And it's like this duality where I'm so proud of that. That like you can be 0 days old to 113 maybe is the oldest I've ever seen.
and we'll figure it out.
Yep.
But the trade-off is we've almost become too accommodating.
Yeah. It reminds me of where the aviation analogy ends too, because like anesthesia maybe still has a piece of that aviation. Like, I'm not flying this plane. We're not taking off.
Yeah, the safety
And-
lever, the alarm is dinging.
Yeah.
We are not flying a bucket of metal into the air.
Yeah, and our alarm is dinging every day in every ER, and the patients just keep coming in, and we're expected to keep trying to figure it out.
Yeah.
So, and eventually people say, you know what, this is enough. Like, I'm not going to keep doing this. And so I hope that ACEP can help be part of the solution to push back on that and say, you know, this isn't okay anymore.
Yeah. What do you see ACEP's role is here? Is it really like setting policies and guidelines? Are there more teeth that ACEP should or can try to have with health systems, employers, ER groups?
We're trying a whole bunch of different strategies. The challenge with boarding in particular is it's not actually an emergency medicine problem.
Totally.
It's a health system problem that comes to a head in the emergency department, but there's nothing you can do to fix the emergency department to fix boarding because it's not an emergency department problem.
Yeah.
The best analogy is Gabe Kellen's analogy. I'll attribute it to him, is that you don't fix constipation by building more colon.
The best analogy. Yes.
So you can't just like build more ED beds and think that you've solved your problem. That is not how this is going to work. So that's one of the challenges for ACEP is that we can't fix emergency medicine to fix this problem. You have to fix the whole healthcare system.
Yeah.
So we're working on what we can do in that space. So we worked with AHRQ before they had their big budget cuts. So we'll see where things go.
I think it's the Agency for Healthcare Research and Quality.
Yes.
Yeah.
Exactly. Yeah. So, kind of an HHS sub-agency. They've done some good work trying to figure out where we can go on this. We've talked with the CMS, Center for Medicare and Medicaid Services, about changing the conditions of participation. So the conditions of participation are kind of the rules that you have to follow as a hospital.
If you want to get those juicy Medicare dollars.
Exactly, which everyone does, even though th're not the best dollars. Like you still
they are dollars.
They're dollars.
Yeah.
And that's actually what JCO is going and enforcing. So the Joint Commission, if it's DNV for your hospital, some German words, don't ask me what it actually is. But what they're doing is enforcing the conditions of participation.
Okay.
So we did meet with the Joint Commission to talk about this problem. And they said, we agree with you. There's actually some former ER nurses working there. They're like, we agree with you. This is a problem. We want to address it. But if it's not in the conditions of participation, like we don't have
the enforcement power kind of.
Exactly.
Yeah.
So that's why we're working on getting that added and figuring out different ways to approach it that way, working with other medical organizations, trying to talk to the American Hospital Association a little bit about this, and just seeing what we can do.
A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. Hey, today's episode is brought to you by Abridge. We all feel the weight of clinical documentation that follows us home and chips away at our personal time. With Abridge, clinicians can change that. Abridge drafts a structured, clinically useful note at the point of conversation, all seamlessly integrated into Epic and customizable to your specialty while you review and finalize every word. Clinicians have reported significantly less after-hours charting, improved satisfaction, and dramatically lower burnout. Let technology support your day instead of interrupting it. Visit abridge.com to learn how you can focus more on patient care and less on paperwork. Let's put the care back in clinical care.
There's some really interesting ideas out there, too. Like, what if we incentivized all the care that was provided between 4 p.m. and 7 a.m. and gave you a boost for that? And what if we incentivized you to provide care on the weekends so that there might be more consideration of doing surgeries on the weekends? Like, there's no actual reason why one can't have an echo on the weekends, an elective surgery on a weekend.
Emergencies happen 24/7. We know that. And the idea that things shut down after 5 p.m. on Friday until 8 a.m. on Monday.
Yes.
Yeah.
And so because the emergencies are always coming in, what can we do to like level out the rest of the system?
Yeah.
We all know Mondays are the worst day in the emergency department. It's not actually the arrivals that are the big problem on Mondays. It's the fact that you can't get any beds because they're all being held for elective surgeries and
Yeah.
that kind of thing. So thinking about ways we can try and adjust the system to better serve our patients, honestly,
Yeah.
because our patients are suffering in the hallways and struggling. So that's the good part about this. There's not really a good part, is that patients and physicians are really, emergency physicians are really aligned on this, that this is a problem we got to solve.
Yeah, I mean, patients will very commonly come up to me and be very frustrated with the situation that that they are certainly in, and that I'm kind of the representative of. And I say, look, I completely agree. I wish we had a psych bed for your child. I know I wish things were different. Please, like, help me. Write to your congressperson, write to your state senator, your state legislator, that these are the problems that I face every day. I know this is new and upsetting and awful for you. And this is unfortunately, what is
every day
normal and accepted in emergency departments across the country.
And most patients are gracious in that situation.
Of course,
and then occasionally some are really angry. And that both adds to our burnout and moral injury. And then sometimes they go so far as to get violent towards us or staff. And then that amplifies burnout too, because violence is not something any of us should face in our workplace. So it all kinds of snowballs together.
I think that emergency nurses even more than physicians face way more violence and biting and grabbing and threats. And that it's kind of like an accepted, well, you signed up for this.
That's what happens.
If you were walking down the street and you did that to a random citizen or a police officer, you are going to jail and you're going to get, prosecuted. But if it happens in the confines of a healthcare system, it's somehow acceptable. Alison, I want to talk with you and move on to a topic near and dear to my heart: physician reimbursement, financial pressures that the whole healthcare system is seeing. It obviously trickles down and impacts our salary, our pay, but the whole system is seeing massive shifts in Medicaid and Medicare reimbursement and massive changes that are going to happen. Do you have a sense of where things are going to land in the next few years?
What I see as the biggest threat in the next year or so is the cuts to Medicaid.
Yeah, agreed.
So what we saw, when the ACA passed, we weren't sure really what the full impact of Medicaid expansion would be on physician compensation. But it happened, and we had the benefits of it being kind of a bit of an experimental design, because not every state expanded Medicaid. And what we saw is that it helps. Yes, Medicaid expansion is inadequate, and we need to keep advocating for better Medicaid reimbursement and better access to care for Medicaid patients too, so they're not having to come to the ED to access care. So I'm not arguing that Medicaid is an ideal system. However, if the alternative is that those patients are completely uninsured and still coming to you, that is even worse. And so we saw evidence that Medicaid does improve physician compensation and reimbursement.
I mean, in the same way that we are really proud to take care of anybody, I think we're also really proud of EMTALA. That, legally, I'm not allowed to look at your insurance status until I start my evaluation of you. But the trade-off is that I think ACEP has put out literature that I think every emergency physician provides $100,000 of kind of uncompensated care, free care every year. And so you can imagine, if you have some portion of that, it now has some reimbursement. That's going to improve and reduce the amount of care that we're delivering that actually we're just kind of giving away for free. We took this oath thing that says patients are supposed to come first, and I think we all generally agree with that. But I think there's a sense that goes so far to say that physicians should just look past that, or that our pay shouldn't matter. Everyone else in the healthcare system seems to be fine. The health tech companies are negotiating big deals. No one is asking Baxter or whoever to give away IV catheters for free. No one's asking nurses to work for free. But
no one's telling United you can't have those kinds of profits because you're in healthcare, and that's not what we do here.
It feels weird that we're physicians, and so we should do this for free, or we should do it uncompensated. But if that were the case for everybody in the health system, we had COVID, we're all going to take a hit together. I think I'm a weird kind of socialist in a way that I'd be like, yeah, I get it. We
Yeah.
signed up for this healthcare thing. We're all going to take a hit,
Yeah.
but we're going to take it together.
Yeah.
But that is not what it feels like and what it comes across. It comes across as, sorry, physicians, we don't have any extra money to compensate you for all of the care that you delivered during COVID. But then you see in the news, GLP-1s and pharma have stocks going through the roof, and United and Optum are making record profits. That's, I think, the piece that really gets under my skin is when I'm working hard, I'm risking my life during a pandemic, and yet I'm told, well, no, we really don't have room for a pay raise for you.
This really gets at the topic that when I've been going around and speaking around the country this year, I've been talking about, which is the financialization of emergency medicine.
Okay.
So there's a paper by Ann Applebaum from 2021 about financialization in U.S. healthcare. It's talking more about hospital systems, but I think the same thing has happened to us in emergency medicine.
Tell me what financialization.
So the concept is that the financial system, manufacturing has been declining and the financial system has been growing since the 50s, right? So the financial system looked at healthcare and said, there's profit opportunities here. There's growth opportunities here. We're going to come into the system. And that's what we've seen, the involvement of private equity in emergency medicine. There are ways that we can increase the profit in this system. But when they're coming into increasing the profit in the system, they're not wanting to increase that profit to the people doing the work. They're wanting to increase that profit to a financial system. And so there's called outside in and inside out pressures. So the outside in is the financial system saying, hey, we can improve efficiency and increase profit. We're coming in. And then the inside out is the nonprofits that are competing with them saying, hey, look over there. They're doing all these new things and we got to compete and we got to negotiate with these insurers that are increasingly profit driven. We better get on this more profitable, profit driven, money driven, extract the dollars system. Otherwise, we're not going to stay alive. And I think that is really what's led to physicians feeling a loss of autonomy, too, because the systems efficiency measures and why don't you work faster and harder and, document better and do all these things differently so that we can extract profit doesn't feel good. You're not making your own choices and you're not even always seeing those monetary gains that you're producing yourself because they're going out of the system.
And, we talk a lot on off call that I don't think it's really just about money. I would understand if a health system said, we literally are in the red this year. We can't give you a raise this year. But what I would love for them to say is, but here's other ways that we could help you. We can have another nurse. We can afford another nurse for the entire department for a year or something like that. Or we can have pharmacy open and more available, or hire an ED pharmacist, or hire a geriatrician or a social worker. There are other things.
We'll start using hall beds upstairs in the inpatient units instead of just in the ER.
There are other things besides just the dollars and cents in our paycheck that makes us say, I'm so excited to go to work today versus, oh God, I cannot go back there today. And it is those thoughts in people's heads that make them ultimately decide, I think I'm going to leave this profession. I was talking with a couple of people at the conference yesterday. I think it really should concern our profession that a lot of people at the conference, look at me, myself included, we are all finding ways out of our profession. That we are finding ways to get away from the bedside because the full-time bedside work of emergency medicine is often not a sustainable career for a, whatever it is, 25, 30, 35-year career. And I don't think that's the case in many other fields. There are certainly all of medicine is a stressful career, but I don't see that same pressure to find, trying to sink your teeth into something else, to buy down your time or to innovate and start a company, do something else. I don't see that in cardiology or oncology or rheumatology or
Some of it, I think, goes to that emergency medicine spirit of I'm a problem solver and I'm just going to do it and I'll figure it out.
I'm going to take the risk of trying something new.
So I think there's a little bit more of a positive spin on that too. But the other side is, we're the most burnt out specialty in all of medicine. The data every year shows it. Sometimes critical care is up there with us.
Good try, critical care.
OBGYN sometimes approach it, but the consistency with which we top those lists is really concerning.
It seems like the House of Medicine should want to find a way to address that. I'm going to get older and need emergency care at some point. My parents are going to need emergency care, knock on wood, not for a long time. And I think it is so important that we have dedicated human beings who've decided to go to medical school, go to residency, and say, yeah, I'm up for anything. I'm up for the concept of just dealing with anything that walks through the door. I will figure it out and help that other human being.
Yep.
And I really worry that if things don't change, those people will find other opportunities because they're bright, smart, committed, hardworking people, and they'll find either another medical specialty or they're going to the lucrative health tech industry and won't be there when somebody's having a heart attack or has thyroid storm or some rare thing that you really need emergency training to understand and recognize.
Yeah. Absolutely agree. I think the best way forward that I've been able to kind of think about and figure out in my time on the ACEP board is to try and give the employees, the workers, the people doing the work of seeing the patients more information, more autonomy, more authority to make decisions for how the system's working.
Yeah.
Because I think as long as we have that, the burnout does stay lower. And it can be, riskier at times, but the protections that you can give yourself in that sense of like, okay, I'm doing this for a reason and I have some ability to pull some levers. So that's what we're really trying to talk about more as a college.
I like that.
And that includes talking about kind of your rights as an employee and understanding those better. But it even goes as far as talking more about unionization.
Sure.
And it's not going to be the answer for everybody, but it's something that more and more people are wanting to say, like, what would that look like? And what could that get me to feel more empowered as a worker in this really challenging system?
10 years ago, I think I would have said you're crazy for even saying that.
Yeah.
And that that is not the vibe at all. I'm not here. But I think things have gotten so challenging.
Yeah.
And the balance of power has kind of gone so out of whack that I think physicians who traditionally I don't think are particularly pro-union people have started to say, I wonder, tell me more.
Yeah.
I'm curious. I'm not saying I'm interested, but
curious.
I'm curious,
I think curious
about
is a great
what
word.
the pros and the cons of a union would be, which is very different than when I finished residency.
And maybe
12
I'm
years ago.
coming at this partially. I was unionized as a resident, which
same.
was really
I
unusual.
was as well.
Yeah, were you?
Yeah, and you're. Yeah,
okay.
Yeah.
University of Michigan, when the auto workers were all, doing their U of M was like, yeah, we're going to unionize. So, and it didn't change my relationship with my program director. My benefits were a little better than average, but it wasn't like I was thinking about it every day. Like, oh my gosh, I'm in a union. So I think that there's a benefit of just having that increased ability to negotiate and understand the terms by which you're employed as a group. Yeah. That you can get through unionization or potentially through other methods. So ACEP's doing other things to try and increase transparency for physicians with their employer as well.
Yeah.
And one of the triggers for this was seeing the APP and NES bankruptcies and how horrible that was for the physicians who'd been working for those groups, losing paychecks for their shifts worked, losing tail coverage, and even losing the end of their working, their malpractice coverage during those shifts. There wasn't even claims made because before the company fully went out of business, they had stopped paying their malpractice premiums.
Oh my gosh, yeah.
And so that more than 30 days had elapsed before the physicians even realized, oh, I actually don't have malpractice coverage anymore, even though my contract says I should.
Wow.
But then by the time they could follow up on it, the company's bankrupt and there's nothing.
It's gone. Yeah.
So ACEP's trying to figure out, okay, what can we do to stop that from ever happening again? We watched it happen twice.
Yeah.
We do not want to watch it happen a third time.
Yeah. Alison, what's next for you now that you're past president of the American College of Emergency Physicians? What's next for you in your interest in policy and regulatory change and trying to improve our specialty?
Well, I'm not giving up on ACEP, so I'm going to keep staying involved in all of the advocacy work that we're doing, and especially some of this employee empowerment work. I just think it is so important, and I am not ready to let it go yet and fully ride off into the sunset. I also recently moved from Houston to Seattle, and I am now the regional dean for Washington State University's medical school in the Seattle area, and so that is a really fun position as well, getting to educate and empower the next generation of physicians and tell them how awesome emergency medicine can be.
Well, Alison, it's been a total pleasure to get to talk to you. Our first live podcast, in-person podcast together.
Yeah.
Again, thank you for your time. It's been a great conference at ACEP 2025.
Great to have you. Look forward to working together.
Thanks.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.